Welcome everyone to our podcast on the arthroscopic treatment of elbow contractures. Today our focus will be to look at the surgical indications for arthroscopic release of elbow contractures as well as the standard procedure for this operation. Throughout we will also review special considerations when performing an arthroscopic release, specifically in the contracted elbow. If you'll remember from our previous podcast, the underlying etiology of elbow contractures is quite varied, ranging from traumatic to atraumatic and encompassing a variety of tissue structures and pathologies. Additionally, we've also seen that the cause of an elbow contracture can be from extrinsic or extra-articular causes, intrinsic or intra-articular causes, or a mixed picture of both. The nature of the underlying contracture is important to try and elicit because it will help to dictate subsequent management. The general functional range of motion is from 30 to 130 degrees of flexion to perform the activities of daily living, but needs to be addressed on an individual basis based on work, hobbies, and other requirements. Patients lacking functional range of motion should all go through a trial of 3 to 4 months of non-operative management before proceeding to surgery, unless an obvious intra- or extra-articular abnormality is blocking ranging of the elbow. Arthroscopic management of the stiff elbow is best indicated for a loss of flexion and extension secondary to capsular tightness, as this is something that can be more easily addressed with a minimally invasive release. Small intra-articular osteophytes, loose bodies, and adhesions can also be addressed arthroscopically. Severe joint issues, including significant malunions and non-unions, arthritis, heterotopic ossifications, and muscle contractures are often better served with open procedures, which can adequately address the underlying pathology. Severe elbow contractures often are associated with significant extra-articular soft tissue contractures that cannot be addressed using an arthroscopic release or debridement. Also note that a significant contracture of the elbow joint also decreases compliance of the joint capsule to up to 40% of its normal counterpart. This can prevent adequate insufflation of the joint capsule, making an arthroscopic procedure more difficult. A previous ulnar nerve transposition is a relative contraindication for arthroscopic management because this alters the position of the nerve for safe portal placement. Elbow arthroscopy standardly uses a 30-degree arthroscope. Low pump pressures from 25 to 35 millimeters of mercury are commonly used to help minimize soft tissue swelling, which can be substantial during arthroscopic procedures. Blunt trocar should be used to prevent neurovascular and articular cartilage injury because the elbow joint is much smaller and tighter than a knee or shoulder, especially in the setting of a joint contracture. Patient positioning includes the lateral decubitus, prone, and supine positions based on surgeon preference and underlying pathology. Drawing important anatomic landmarks in the surgical field ahead of time will help to minimize confusion and protect important structures. The joint is also often insufflated with normal saline prior to trocar insertion to help prevent damage to the neurovascular structures and articular cartilage. Again, note that the contracted elbow is often more difficult to insufflate and nerves can be contracted within soft tissue contractures, increasing the risk of damage to surrounding structures. Drawing important anatomic landmarks in the surgical field ahead of time will help to minimize confusion and protect these important structures. Important initial landmarks include the medial epicondyle, ulnar nerve, medial intermuscular septum, olecranon, lateral epicondyle, and radial head as shown here. Usually, the anterior compartment is addressed first because it carries a higher risk of nerve injury and is easier to address before swelling is substantial. The joint is often insufflated with normal saline through the lateral soft spot shown by the arrow prior to trocar insertion to help prevent damage to the neurovascular structures and articular cartilage in the anterior aspect of the elbow. Again, note that the contracted elbow is often more difficult to insufflate and nerves can be contracted within the soft tissues. The first portal is the posterior anteromedial portal shown by the circle. This is made 2 cm proximal and 1 cm anterior to the medial epicondyle, and the cannula is directed anterior to the intermuscular septum and into the elbow joint. This is followed by the generation of the lateral portals under direct visualization, for example, the proximal anterolateral portal shown here. The anterior capsule is released from the lateral side of the elbow to the medial side. When working on the lateral side, stay 2 to 3 centimeters proximal to the radial head to avoid injury to the radial nerve and its branches, which run between the brachioradialis and brachialis muscles. The deep radial nerve branch also runs adjacent to the anterior joint capsule in the distal half of the elbow, and caution must be taken in conditions that cause scarring of the radial head to the joint capsule in this area and increase the risk of nerve injury. A combination of biters and shavers are used to perform the release, which is adequately performed when the brachialis muscle is easily visible. There are 3 portals which can be used for posterior elbow debridement. These portals are generally safe and farther away from neurovascular structures than in the anterior portals. The first and main viewing portal, the posterior lateral portal, is made 1 cm proximal and lateral to the olecranon tip, whereas the direct posterior portal is made 2 to 3 centimeters proximal to the olecranon tip through the triceps. Initial debridement in the lateral and midline posterior elbow will help with visualization, but ensure to be careful posterior medially where the ulnar nerve lies in weight. Any loose bodies or osteophytes from the olecranon or olecranon fossa can then be dealt with, and the ability to achieve full extension of the elbow can be assessed. This is then followed with release of the posterolateral and posterior medial joint capsule and adhesions between the triceps tendon and the humerus. Murray and colleagues described the factors that help to contribute to a successful arthrolysis. This includes achieving maximal intraoperative range of motion, starting early postoperative range of motion, and providing adequate pain control postoperatively to help with ongoing maintenance of motion. Of special note, in cases of significant loss of elbow flexion of less than 90 degrees or preoperative signs or symptoms of ulnar nerve irritation, an ulnar nerve transposition is often required. Because the ulnar nerve runs behind the medial epicondyle, it undergoes stretch and increased pressure during elbow flexion. After release is performed and the elbow flexion is increased, decompression is likely required to prevent traction injury with the increased range of motion. Having achieved our objectives for this short podcast, we will end here. Open release and postoperative care will be reviewed separately.